My name is Lisa Saloom. I'm a PGY1 internal medicine resident at University of Texas, Rio Grande Valley at Valley Baptist Medical Center. And the title of our case is Unveiling Acute Lymphocytic Leukemia, Exploring Structural and Numerical Alterations. Acute lymphoblastic leukemia is an aggressive cancer that's caused by abnormal growth of B or T cell lymphoblasts. The diagnosis primarily involves bone marrow biopsy that shows more than 20% lymphoblasts, along with flow cytometry and cytogenic analysis. And the cytogenic analysis is used to detect chromosomal abnormalities, the presence or absence of which can help determine prognosis. One of these abnormalities involves something called a complex karyotype, which is defined as 3 to 5 abnormal chromosomal patterns, including deletions, translocations, or rearrangements, and this is typically associated with poorer outcomes. Treatment of ALL consists primarily of combination chemotherapy, as well as vigilant management of infections and low blood cell counts. Our case involves a 44-year-old male with past medical history of heart failure with reduced ejection fraction as well as type 2 diabetes, who came to the emergency department with 1 day of generalized weakness, dizziness with standing from a seated position, blurred vision, and shortness of breath. Initial vital signs were unremarkable, and his physical exam showed a patient who was appearing tired but without any active bleeding and conjunctival, paled conjunctiva. His initial labs showed a white blood cell count of 1.9, hemoglobin of 6.9, and platelets of 21. Given the pancytopenia, he did receive further workup with a bone marrow biopsy that showed B lymphoblastic leukemia/lymphoma with 75% blasts, causing a markedly hypercellular bone marrow. Flow cytometry revealed 40% variably sized cells with predominantly positive surface markers of CD10, CD19, and CD20, as well as partial positivity for CD33. And cytogenic analysis revealed 18 cells with a complex karyotype, which included multiple structural and numerical abnormalities, including structural rearrangement of 7q, trisomy 9, deletion of 9p, and an unbalanced 15-16 translocation that led to the loss of 16q and gain of 15q. So these are both images of a bone marrow biopsy of somebody who would have ALL, seeing the predominance of these large lymphoblastic precursors, and the diagnosis is made with more than 20% of them. Flow cytometry will predominantly show in a B-acute lymphoblastic leukemia, predominantly positive CD10, CD19, and CD20 surface markers. So this patient received hyperfractionated CV80 chemotherapy, which included intrathecal cytarabine, vincristine, methotrexate, IV dexamethasone, rituximab, doxorubicin, and cyclophosphamide. Due to side effects associated with rituximab, it was discontinued, and during his treatment, he did develop electrolyte imbalances that were concerning for tumor lysis syndrome, so he was managed with allopurinol and sodium bicarbonate. The patient also received subcutaneous filgrastim to help counteract the chemotherapy-induced immunosuppression, and he received infection prophylaxis with acyclovir, ciprofloxacin, and fluconazole. His stay was complicated by anemia and thrombocytopenia that required 12 units of red blood cells and 11 units of platelets to be transfused. His pancytopenia did improve, and he was discharged with IV ceftriaxone for bacteremia that was found during hospitalization, as well as instructions to follow up with oncology and infectious disease. So some conclusions from our case are that B-ALL is typically present in a bimodal distribution, mostly in young children and adults over age 60, but in our case, our patient was somewhere in between. And classically, the presence of Philadelphia chromosome on cytogenic studies also confers a poor prognosis. However, other less common karyotypes can be present. And in this patient's case, he had a complex karyotype that is linked to poorer outcomes. So the take-home point is that ALL typically requires management with chemotherapy, management of infection with prophylaxis for antibiotics, management of bleeding, and by tracking his blood counts, and that these complex karyotypes may be linked to poorer outcomes in patients with ALL.